Rise of the Resistance is a festival about responses to AMR, which is antimicrobial resistance. And it's produced by Nosocomial, which is a theatre project combining healthcare scientists, patients, and artists that rotates loosely around myself and Elaine Curtin-Green from Ormond Street Hospital, but is a kind of collective that rises and falls. In partnership with Precision AMR, which is a research project at UCL and Great Ormond Street Hospital and Institute of Child Health. This festival is to look at antimicrobial resistance and the kind of wider implications for health as a global responsibility for our human species. We invited various people to respond to the theme, and Rahila Gupta has written this piece and conceives this idea as a response to the theme. We'll watch the film. Have you seen it yet? No. Which is about 6 minutes long, and then there will be a panel discussion between Rahila, between Sonali Naik, who's a QC, and between Dr. Enrique and Castro-Sánchez on the themes that rise from it. Okay, thank you very much. Hope you enjoy it.
Tombstone cast its shadow. Do you hear, Rodolfo? My dreams drowned in the fearful sea between Turkey and Greece. I crept into your heart, you crept into mine, looking for life above ground and sunshine. Now I drown in mucus and night sweats. I no longer own my body, I have no home to call my own. My future has shut down. My past is a place of nightmares. I must wander everywhere. This is my journey to silence. Oh, my icy cold hands, one last time, please, Rodolfo.
The conversation will ensue between Rahila Gupta, who, among other things, has obviously had quite an extensive connection with South Black sisters, and is also a poet and a playwright and an activist and author. And I think puts all of those elements of her interest into this kind of extraordinary piece of writing. Dr. Enrique Castro-Sánchez works in infection prevention, as an infection prevention nurse in the community in the UK and elsewhere, and also worked on TB, particularly with World Health Organization. And Sonali Naik, you see, is somebody who's at the forefront of what's happening with immigration law and actually dealing, well, I think it's fair to say that all three have met Mimi's in various ways. Rahila, do you want to talk a little bit about your stuff?
Yeah, I mean, I'll talk about the way the whole project started, really, because I'm actually very new to opera, so I have to admit that I've only ever seen, or at the point of writing this, I've only ever seen one opera, and that was partly because a friend of mine took me to see La Boheme in Ali Pali Car Park. It was a kind of an educating Rita kind of adventure, and the great thing about only ever seeing one thing in a particular genre is you remember it in great detail. And plus, I joked with my friend and said, you know, Puccini made a mistake because he gave Mimi the wrong disease, because how can you be an opera singer and be breathless at the same time? And so that remained with me because I've got a really poor memory, but if I've cracked a witticism, I sort of, you know, hold on to it. So when Nicola put out the call saying that she was looking for artists and writers to engage with this theme, so, you know, first of all, the acronym AMR, my eyes kind of glazed over. Then you sort of spelt it out and said antimicrobial resistance, and my eyes still glazed over. Partly, I think, to do with my terrible schooling in India, where at the age of 13, because my maths was so poor, I was just shunted off into the arts. So, you know, I have this desire to engage with something that's really difficult, like for me, science, and find it. And I have engaged on it on various occasions, actually, with white touring, you know, a lot of scientific subjects that I've dramatized, but they're really tough to do, I think. Anyway, so I thought, oh, great, I think I'm going to rewrite. Never mind, I've never seen opera. I don't know what the rhyme scheme is. I don't know the sort of shape and structure and musicality of it all. But I just thought, yeah, I'll do that. And then Nicola said, she started off the conversation and she said, well, you know, I'd really like you to write something about migrants. And my heart was sinking. She was saying, you know, that I want the kind of health implications, because I'd written a few years ago, I'd written a book on modern day slavery and which I said was a result of immigration-led laws. So she was very keen that I write a migrant story. And also I couldn't imagine, my first response was, oh God, that could have racist overtones, because the whole thing around migration has been, they bring diseases with them. So I thought, how is there a positive perspective on it? And then you gave me that positive perspective by saying, well, actually, if immigration laws, if people felt that they could have access to healthcare, it would actually be beneficial to everybody. And so there should be a kind of an openness around immigration and the services that are available to migrants. But I was kind of stuck by this time on wanting to rewrite Mimi's. When she finished talking, I said, oh, but I wanted to rewrite Mimi's aria. And she went, yeah, okay, so make her a migrant. And I went, oh yeah, okay. So we managed to achieve both things. So then began my self-education in opera, and this is the result.
We'll come back around the thing, but Enrique?
I mean, we can frame AMR from like a clinical or biological point of view, isn't it? So health problems, drugs or bugs, but I think that the context that the opera brings and the story brings, the political undertones, the rights-based approach, and the vision about how we're all interconnected, it's what makes it really interesting in my point of view, because we're really not going to win the battle with the bugs and the drugs that we have, really, and it may be that we really need to bring that, our ideas about, what's the economic model we've got in mind that's forcing people to be enslaved, so we can have cheap clothing and living in squalor. And I really like how the video, maybe just shows privilege, but the conditions seem poor and sort of deprived. And again, AMR, TB, great examples of that deprivation and dispossession. And we know actually that migrants are not bringing diseases, migrants are not bringing AMR. We have got excellent data that tell us migrants pick up AMR in the journey, and that journey is shaped by our political decisions and our political choices, us that we've got right. So again, we are in a way responsible for the AMR journey, and then by the time they appear in our hospital, in our clinic with AMR, we think they brought it, but actually we gave it to them. And I find that quite sobering, and we have got powerful data that tell us that. So I think that moving away from the biology is much more interesting and probably useful to try to address this issue, or these issues. Really.
And just to spell out that AMR, just to say what that is more eloquently than we can.
So it's AMR, antimicrobial resistance, but really we should talk about drug-resistant infections. So they are infections which are difficult to treat. Some of them are not treatable at all, and that's an increasing problem driven by many factors, but it's a Darwinian mechanism. Bugs will adapt to the drugs we use, and that battle or that adaptation has been going on forever and will continue going on forever because it's a natural mechanism. It's simply Darwin. So flexibility and adaptation, but they are infections which are difficult to treat, really, just to keep us.
I mean, actually, that's the first time I've seen the film, and it really brought me back to where I started in my work, which was at Tower Hamlets Law Centre. Obviously, the film was filmed in the East End, and I feel like I know that block. I've seen that woman, or a woman like her. I represented loads of textile workers, and in the 90s, when I was working there, that was the first time for a long time, I think, that health services started to see TB cases, which they hadn't seen for generations almost, I think. And so it really resonated with me in terms of, if you put people in poverty and squalid living conditions, their health suffers, and then they will become more vulnerable to other infections that other people will fight off, or won't be able to respond so well to treatment. But that woman is an archetype. So I've represented lots of women who came here, migrated as spouses, and if you come here and you're documented and you have immigration status, then you may get into the healthcare treatment. But if your marriage breaks down, or if you flee domestic violence and you end up living outside of the system, then Mimi is a real character, and a real modern day character, which is a shock that we can tolerate a society where Mimi did that, what we thought was a sort of early 19th century model or figure, actually could and does exist today. We've seen them in our, when I used to run an advice session in a sort of Tower Hamlets, and people would come, they wouldn't be even bold enough to come to the office. They'd come to an advice session that was run in a community centre that was not connected with anything sort of formal, and you would then hear the stories as to what they feared and how they were unable to access, you know, healthcare was one of the issues, but so many issues, unable to access safe accommodation, you know, even access to food and support. And with that, the undocumented migrant or someone who's living outside of the immigration system ends up very much like Mimi and would be totally exposed until the point where they need emergency treatment. It's only when you need emergency treatment that the healthcare system will kick in for people who are undocumented or don't have the right papers or the right leave to remain.
I'm quite interested as well in the fact that you're saying about, I remember you also mentioned about women coming to have access to clinics in a way they wouldn't go to the health service. I know that you've quite recently run a writing project there, and picking up on what you said, that when you were thinking about how you want to express the theme, that you felt like there was a creative way in to talk about a lot of complicated issues. And I wondered if you found that when you're working with groups as well, that actually through asking people to write stories, it can help them to access other things.
Oh yeah. I mean, certainly, I think the women, when I was running the writing project at SBS, the women were very driven by this need to communicate to other women what they had been through as a way of sort of should never happen to anyone ever again. So there was a kind of an idealism and an altruism that drove that whole process. But of course they've been so used to giving their stories to caseworkers, lawyers, in a particular kind of way that for, you know, which began with my name is this and I was born here and so on and so forth, to try and break out of that manner of storytelling and to actually either go into one little incident rather than their whole kind of journey. It was quite a difficult thing to do, and also it was very traumatic because, and I kept saying to them, there would be tears and I'd say, you don't have to write about this, you can write about your day at the factory or whatever, and they would say, no, we want to write about this, it's got to be done, it's got to be said. So there were sort of various exercises and ways of, I don't know if it's probably far too detailed to go into the sort of various ways of releasing them from the trauma or the moment or the reliving of it and then going back into it, as it were. But just to talk about the other thing we were saying, I know that recently Salva Black Sisters were very keen on setting up a vaccination hub in the centre in the hope that women who felt anxious about, you know, being found out or traced or whatever, going to a NHS sort of approved hub, that they would actually, that's the big danger, because I think as far as infectious diseases are concerned, I think the small print says that undocumented or not, you will get treatment, but the fear, the climate of fear that is being produced by more and more draconian legislation, and at the moment there is a bill that is going through Parliament, which is basically criminalizing asylum seekers. There's no non-criminal way of entering this country. You know, at the moment you enter it without papers, you're a criminal. So that climate of fear means that they don't want to access whatever health services there are because they're afraid. And so they, but apparently this is what I was told by one of the women at SBS, that they applied for, you know, permission to run it, and it was denied for various reasons. So then they organized an online seminar where an NHS doctor who I've spotted in the audience, who came along and spoke at it at the Zoom meeting, along with a campaign group called Patients Not Passports, which argues for no borders in the NHS. And apparently some of the women felt that the reason they didn't want to take it is because they would have a tracker inserted in with the jab so that they could be found and could be followed. So all of these fears were laid to rest by the people who spoke at the seminar, and I believe that a lot of the women then did go along and get jabs. But it's that kind of atmosphere that's being created at the moment that's very hard to.
And I remember the other day, both of you were saying in different ways you come across that sense of the small print and the practical.
I mean, the process of trying to get, everyone here, I'm sure, had a COVID jab, but the process of getting that required a lot of paperwork. There was no real way you could just do it by turning up at a centre and getting a jab. You had to be on a list, you had to fill in forms, you had to come back for your second jab that was all documented, you had to be sent a text message to turn up for the appointment. Nobody who is worried about their immigration status or is undocumented is going to really likely to take that risk of being found out through the process. And once we allowed, once we required GP practices to require proof of identity, proof of residence, before we could even really get across the threshold, that's the evolution of the kind of internal controls and the denial of access to healthcare in the lifetime of my sort of 30 years in immigration practice has become ever increasingly draconian. And so you won't go into a GP surgery if you think, well, what happens if they report me? I know there are organisations, as you just talk about patients, not passports, and doctors, not cops. Doctors don't want to do that. Healthcare professionals don't want to do that. But they are required to ask people for proof of their identity. And we are now, because of COVID, increasingly, compliant with being asked to produce our COVID certificates when we want to go to the theatre or to producing documents to access other services. And so it's going to increase that dichotomy of those who will be able to participate in the system and those who will not. And there will be, yes, in theory, the infectious diseases are accessible for treatment and for diagnosis and treatment, but how will, people won't necessarily know anyway whether I'm on the Schedule 1 list of the Overseas Charging Treatment Order, whatever it is, or not. And they won't just think, oh, I think I'm worried about a lump in my breast, should I go and get a screening? Well, that cancer isn't on the infectious diseases list, so you would be charged, and then you would be on the system as well. So in both senses, you can't get the treatment because you can't pay for it, and you might risk being identified. So there's so many reasons why the system is going to increasingly discriminate against persons without immigration status.
And it clearly assumes that everybody's got this really well-organised life and this sort of safe and tranquil life where we can think about, well, I need to make sure I pop into the GP so I can have my COVID-19 vaccine. But if you are, couch surfing, worrying about any police car that, you can hear or anything remotely related to the state and the distrust that many people may have with regard to the state because of their previous experiences where they're from. So they're not really going to make a decision to come to an NHS service or any other kind of official service so they can have a vaccine for which they may not have even heard what it does and what it means. And again, I find it really uncomfortable that we place this massive burden of responsibility on the individual when it's the system that's driving the options that they can exercise rather than their choices. And I find that we place that burden particularly on those who are least likely to be able to make choices, rather than the system. When we talk about the vaccine coverage, we always sort of think about, well, this particular group, but have we actually thought if this particular group has access to vaccination? Thinking about travellers, for example, what are we doing for people who don't have a fixable, for many reasons, by choice or not by choice? Because it's quite easy to sort of stigmatise and demonise groups who don't conform to our traditional way of living, and blame them for we're not reaching 100% of vaccination coverage, or people are not really coming to the GP when they've got symptoms. It's easy for us to sort of, again, apportion blame, but the system is really shaping those choices often.
And also you think about the burden of responsibility, it puts the burden of responsibility on medical professionals as well, on you have a patient in front of you that you want to treat, you want to advise, particularly if you're working in the community as you do, which draws you into that kind of state level practice inevitably.
Well, the overlap between sort of like a health and clinical decisions and forces and non-health and non-clinical decisions are truly driving what we're seeing in the opera, isn't it? I mean, the treatment is the biological, again, the drugs and the bugs, but people are placed at risk for non-clinical reasons, for non-health reasons, and again, as a clinician, as a doctor, as a nurse, as I am, kind of your choices are quite limited, because what can you do about someone's employment conditions? What can you do about employment policies, labour legislation? What can I do as a clinician that will end up improving the health of my patients and citizens? Because more and more my patients are not the people in the consultation room. My patients are citizens in the country, citizens of other countries, that global perspective, that interconnection that we're seeing with AMR, which is important.
And I think the real tragedy is that this Mimi that we see here is coming after the invention of antibiotics. In the 1830s, we didn't have antibiotics. So it feels even more sort of devastating that we've invented medication that could help, and then through abuse and as you said very eloquently, that it's actually about excess. There's this question of excess versus access, that it's the excess of in our society where you just throw antibiotics at a problem without dealing with it in the sensible and then create resistance. And then there's the question of access, like for COVID vaccines. I mean, universally, we're all aware of the fact that we would be safer. If you want to take a sort of selfish perspective on it, we would be safer if vaccines were distributed around the world, COVID vaccines. But here we are hoarding our stock. And that's what makes my heart, I know it's a bit of a downer, but it makes my heart sink, because if we cannot recognize that now, when we are living through a pandemic and seeing the kind of impact it has on our economic, on everything, health, life, death, etc., how are we even going to tackle AMR? Because it feels a little bit more abstract. It may be the next pandemic, as there are fears that it might be. But if we are not able to see beyond our noses for COVID, I don't know how we're going to manage on the AMR front.
Enrique, you talked about the experience you had with HIV when that was an emerging threat as opposed to being a present threat, and how the treatment for HIV for undocumented migrants or people who were in the asylum seeking system, they were able to get some access for treatment and diagnosis, but not necessarily the kind of actual long-term care that they needed. And that, again, we've allowed the system to create emergency, immediate access, but then you sort of fall off the end of a cliff in terms of support and care that might need to go on for years.
It all depends on the legislation, isn't it? And legislation can change overnight, and the implications will be there to be felt by the people affected by the legislation. But how quickly you can set up care for someone, and then overnight that disappears.
We saw certainly, even for groups of asylum seekers who are, in theory, able to access healthcare, that the government put groups of asylum seekers in Napier barracks, for example, that were not fit for habitation, and actually intensified the risk of them getting COVID, and many of them did, and the courts did ultimately intervene following individuals' claims. But it shows you that government policy was to put people who were vulnerable, some of them, we don't know exactly who was the most vulnerable, but certainly as asylum seekers as a group I would say are vulnerable, into that kind of accommodation which was not usable, and specifically increased the risk of COVID by the proximity people were placed into, the failure to have appropriate, the damp conditions and so on in those barracks. So that's a very recent example of what government policy is towards a particular group of people, even when they're notionally included in the system of healthcare. There's another recent case where, which a colleague of mine did, where somebody was in a detention centre, he had HIV, they knew he had HIV, but they didn't treat him because he was in a detention centre, he wasn't properly treated, he didn't get access to the kind of support he needed, and that was where the condition was known. But in detention or in short-term holding facilities, all the people who are shoved into that system don't get access to the same kind of healthcare that you and I get access to, and they get what is deemed appropriate and reasonable for the circumstances. And then they litigate if they can, and if they don't, they just go without. that's been, that's happened on so many occasions.
I want to ask you all, I'm going to give you a minute or two to think about this, but yesterday we had a very interesting session with healthcare scientists. We did a piece that was based on responses of healthcare scientists who were working in AMR. And we were asking them, what would you like to see happen? What would you like the public to know? And there was an awful lot, as you say, of gloom and doom and the estimation of the amount of deaths that would result from AMR. But as they're scientists, they said you have to approach it as a problem that is solvable. And then you have to work out what you need to do, and you have to do it. And I just want to put that same question to all of you. I mean, it doesn't matter whether it's something that you see as being easily manageable, but I'm going to ask each of you what, from your point of view, you think might help solve it. And to give you a minute to think about that, I would just like to introduce or point out Otis.
That's what I want you to do as well.
Who is here,
voice.
who was the singer for the piece, the most extraordinary. Believe it or not, singing is his side hustle. He's actually a dancer. It was we were forgetting that he did it. And I don't know if Radhika is here.
I didn't see that.
She's been travelling, and I think she may well be watching us at home. In which case, let's give her a round of applause anyway.
And whilst we're on the applause, I have to say thank you very much for the way in which you've scripted, directed, produced, got everything sorted, and it was just an idea that I sort of raised with Nicola, saying, wouldn't it be wonderful if she could sit on a bench in a council estate in East London, not
Sitting
thinking,
up to the window, yeah.
looking up at a balcony, and it would, because women never sing serenades, it's usually men who sing serenades. I wanted to do that reversal, and at that point, I think it was just going to be sung by a singer, either live or filmed or whatever. I never thought you would do it, and you've done it, and you've done it beautifully. It was so.
It was a kind of extraordinary day watching an amazing actress mouthing words that we couldn't hear because she was listening on headphones in a housing estate. And one thing that was very interesting is that when you're filming somebody who looks like she looked, nobody paid any attention. There wasn't any of the oh, what are you doing? Is it on telly sort of thing. It was just
because she was an Asian,
yeah.
in an Asian place. Plus, she hadn't got a famous face, so there were no crowds.
Yes.
Yeah.
So, dream big. If AMR is a solvable problem, what would we need to do to solve it? To help me. Let me start with the scientists, because you're more likely to have a strategy.
Okay. I think it's the way I see it is a terrific opportunity to feel connected to everyone else in the planet, because the way I see it is a bit of like a prisoner's dilemma. We won't be able to benefit if we're just thinking about our own welfare and benefit. We need to play with everyone else and think about what is it that would benefit them, so then I end up also benefiting. We won't be able to resolve this issue with the technology mind and the freedom of mind, technology by drugs, tests, that will not help. It hasn't helped, and we're running out of options. Only in 100 years we've managed to burn through everything we've got quite quickly. So maybe if we think about it as a sort of an opportunity to demonstrate what makes us humans, kindness to our fellow planet sharers, everyone else in the planet, not just also humans but animals, and thinking about that One Health perspective, which in my mind is not just sort of animals, environment and humans, it's also economics and politics and a way of looking at the world. I think that the solution would lie there in that planetary view rather than sort of like the lab and the bench. I'm afraid that I don't believe that would be our way out. But it may be quite a nice opportunity.
I think just speaking up for the lab and bench, because I can see Elaine there. One of the things we've kind of found is that the more we could learn from bugs, the bugs are depleting our medicines because they cooperate, they communicate. Little microbes know that they're not healthy unless all their community's healthy, and they seek out places where they can make sure everybody, so they grow, the bugs grow. And that's why they're doing better than us, I think, because they watch out for everybody in their community.
Well, I was just thinking back about the point about what Mimi needs, or what a person in that situation needs. And because we're all thinking about health, since the beginning of this pandemic, we've never thought about our health or about our collective health so much than in the last 18 months or so. And so it is an outrage that there are people who can't just have access to the thing that they need in order to protect themselves and protect us all. So we should be able to have, as my example of my drop-in advice centre, a place where people can at least go to get basic health care, so that and access to protection if they need it, without having to go through the documented hoops. It isn't acceptable in the society in which we live that you can only access things if you have an app and a mobile phone and a piece of paper to document your immigration status, because we know the reality is that people will die. Actually, not just fall ill. We know the reality is that they will die because they don't get the healthcare that they need, and we can't tolerate that as a society. And when we're thinking about, and it will impact anyway on our collective health, although that's not, from my perspective as a human rights lawyer, the main objective. But it is sellable because it has a mutual benefit. So I think that's why I think it's something that we must at least provide for and make that available, and not, as Rahila said, threaten people with criminalisation for seeking immigration advice, seeking asylum. And that is what it is going to go through Parliament at the moment, and opposition to that principle in the current bill, which is still a bill, let's hope it doesn't become an act, is at this moment in time absolutely critical.
And that's just very briefly in one line, and what's the changes that have
I mean, basically the government wants to undermine the principle in the Refugee Convention that you can arrive and claim asylum, and they want to criminalise people if they arrive illegally, or effectively all asylum seekers arrive without papers, unless they happen to be here and they have a revolution in their country, have to be here lawfully. And so that criminalises those group of people. The Refugee Convention acknowledges that people can't travel lawfully because you can't get a visa to claim asylum. And a resettlement scheme for people to come, like has been suggested in the context of Afghanistan, that we've just, in the current acute crisis, and that we had in the context of Syria, doesn't address the need of people who need to urgently flee and move immediately. And the second part of the bill is to say to people, if you came via a third country, you should go back. You can't make a claim for asylum. And again, people claim asylum in the UK for all sorts of reasons, and quite often because they have a connection here, they speak the language, or for whatever reason it is in their mind, their port of call where they feel safe. And what kind of society are we to criminalise those people who've made those journeys and made those choices? And they may not necessarily be the right choices, but they are the choices that are made. And once they're here, I think it is a moral and legal obligation to admit them into the asylum system and to process them and to grant their status if they fall within the definition. And that's to maintain the status quo, which is what we're fighting for at the moment. I think is really important, and that's what the government are trying to undermine in the bill.
Well, I mean, picking up from what Enrique said about individualism, basically what you're saying is that we have to have a sense of collective responsibility, because it's all our mutual health that as a society will benefit all of us. And I mean, for me, capitalism is the system that encourages individualist way of thinking and individualism. We've got profit at the heart of the big pharma, so the way in which drugs are made, researched, sold, etc. The whole system is like rotten to the core, really. So, I mean, I know this sounds like what you're saying is much more achievable, and would help in certain kinds of ways. But I really do think that we have to bring an end to this system, and I know that feels to a lot of people like unachievable. And I just wanted, as I was talking, was reminded of David Graeber, who died, it's his 1 year anniversary. He's a sort of intellectual. He was part of the Occupy Wall Street movement, etc., etc. He's written some amazing books. He was an activist. And he said something really simple, and which is, what he said was that one of the biggest hidden truths in our lives is that actually the world has been made by us, and we can remake it. I think that sense of empowerment that you get in that one sentence, I think that's what we forget. We feel we can't do anything. This is all bigger than us, you know. And so we kind of go along with something. I'm saying this in a room where I know there are a lot of activists who don't think like that and who've actually made it their business to try and change, you know, the most iniquitous things about our society. But I think that really does motivate you into saying, well, let's do it in a different way, you know, for all our benefits.
I think one of the things that really excited me about your idea for this as well is that it's taking something which is an art form, which is extremely commodified, extremely, you know, like the jewels of our cultural capital, and you went, that this is my heritage, and to kind of turn that on its head, I think it makes a really good point. We could maybe just have a couple of questions, but I also want to bring in the name, if you've got anything as our co-producer of this, if you want to respond for the bugs.
For the bugs, yeah, I'm all for the bugs. We will take it. No, it's fine. I'm just really excited to see the work, and actually as someone who received the letter last week that told me what I had to do in terms of Afghanistan refugees coming over and what the limits of the healthcare provision I was allowed to provide, and because I knew this was coming up, I felt that was really something that was active in my mind when looking at this, because even with those boundaries, and obviously I work in paediatrics, and surely we should never be talking about restricting access to healthcare for children, no matter what arguments you can make on other conditions, which to be honest is beyond me anyway. But that's great for right now. Those people will be coming over with conditions that, you know, like TB, that require long-term treatment. You know, HIV is lifelong treatment. And so I think it's really interesting to have the conversation about how we get longevity of access as well. So how do we make sure that I can't do my best piece of work if I don't have information about someone's health and someone's background? And if that's going to be in a community setting and they don't have access to any form of medical records and they're going to be here for 5 years, how do I do my best work if I can't see what was said to them 4 months ago by somebody else, if it's a drop-in service? And so those are the kinds of things I think that really strike me, in that our short-termism is going to not only have massive impacts for that individual, but you know, I had a case of TB a few months ago where they lived in a house with 23 other people, and those were people that had absolutely the right to access healthcare, but were also not having the conversations to say that TB is a thing of now, right? People think that TB is a thing that happened in the Victorian era and doesn't exist anymore. We don't have those conversations about what modern day poverty is actually driving. So how can we have those conversations with the wider community to say, actually, those people who rent out really poor accommodation to 16 people that isn't up to scratch, how do we hold those people to account and make sure that they understand the impacts of health, not just economics, on those families?
Any questions? A couple of questions from any of these guys? Honestly, covered everything.
So can I just ask, what would you want somebody like me to do? If I get that letter and I am in a position to advocate and it all does feel really big and I don't have your legal knowledge about, you know, where my barriers lie, if I go back to work tomorrow and I get contacted about how I progress someone through the system, when I have that person in front of me, what is the most valuable thing that I can do, say, not just about their direct kind of immediate medical assessment, but to give them that information, access to support, settling orientation.
I mean, I was speaking to somebody yesterday who was just been relocated from Afghanistan, a woman judge. She was still in the quarantine hotel, and she was asking me all of those questions on a Zoom call. And I felt totally inadequate, actually, for the first time, seeing somebody who'd immediately arrived and who was fleeing persecution, but not being able to see them in person. And I was trying to signpost her, and I realised that all we were doing was sending her lots of links to places, and people need that one-to-one support, and you know, even if it is signposting, to so that there's some sort of continuity for them. And I was asking, you know, she's a very well-educated woman, but I did feel that I was like, you know, this is a completely new country for you, a completely new situation. You're in a quarantine hotel, so you haven't even been able to go outside of the place where you are in order to locate yourself and to orientate yourself. So I think if there's any way that you can provide continuity so that she can come back and see the same person. You know, we see our GPs and sometimes we see different people, and sometimes that's upsetting and sometimes it's fine. But for us, we're familiar with our surroundings. So if you could get just continuity to say, I've got to try to, as a clinical model, say that she's got the right to come and see me next time she comes, that would just mean so much to the individual. And that I certainly remember from my law centre days doing advice work, is that I would build up a case file and the person would come and see me, they wouldn't see anybody else unless I was, you know, absolutely unavailable. And that way, that model of the client care, patient care is obviously, I'm sure Enrique knows much more than me, on a personal, on an individual level. But on a policy level, I say that we're allowing the government to provide a different standard of integration for refugees who are resettled, both from Syria and Afghanistan. They get a better, what will be coming from Afghanistan, that we understand, which is that you get access to more support and English classes and so on. But other refugees who arrive, they don't get that. And so they're kind of creating a two-tier, good refugee, bad refugee narrative. So I think on a policy level, if you have any opportunity to lobby, you need to say, well, everybody, all refugees and asylum seekers need this. You can't just have it for people who've been plucked and said you're the most vulnerable, because actually they're all really here with the same needs. So Enrique, I'm sure you know more.
No, I was just thinking that in this sort of like our code of practice and all registered professionals, I do think that those codes have got a really strong core of social justice. And that may be the door to sort of think about, okay, I've got a clinical responsibility to the patient in front of me, and that's sort of building a case. They need to see me, want to see me, but also I'm a citizen of this society, I'm a registered professional, and I've got, you know, again, social justice is at the core of what we do. So that lobbying, that activism and that activist role may be the way. I mean, clinical solutions will not help the rights of your patients, so it's a different sphere, but we do have a role to play there, and probably we cannot ignore that role to play if we are registered, and that's sort of the way I see it. So they are my patients certainly, but I'm also a citizen with an MP and ways in which I can try to be heard. It doesn't depend on me if I end up being heard or not, but I can try to be heard using evidence. Again, you know, evidence-based policy may not be what's been happening, but I accept that policy is not made based on evidence only. Ideology also takes place, influences. But I would look at the code and see myself as activists for social justice for our patients, or not even our patients, for people coming through wherever they come from.
I was actually going to back this question to Pragna, who's director of Example Black Sisters, who has to resolve this, well, in a slightly different setting to that one, but in terms of making women feel comfortable, feel valued, etc. What are the things that we do, support groups, etc.?
I mean, I think it's one of the things that Enrique and Sonali has outlined. I think on a practical level, it is about empowering, creating conditions that empower the individual in front of you. through providing information, but more than that, not seeing them as just users or victims, but as political people with rights, people with dignity and political will, and trying to, at another level, at a political level, is mobilize those same people to challenge and resist and to become agents of change as well. And, you know, in our small sort of way, we work with women who come to us desperate in the way that you've all described, who desperately need our support, who can't access health service. We had a case where a woman, a refugee woman who had cancer, was getting treatment in hospital but kept getting the bills, which ran into thousands of pounds, and she was at a very terminal stage, and she was getting more distressed by the bills that were arriving, and we were trying to support her and say, don't worry, we'll take care of the bills. We were going to challenge the fact that these bills were being presented in this way. We spoke to some of the groups, doctors, not passports, whatever they're called, to try and see if we could get their support in challenging the fact that this refugee woman, terminally ill with cancer, was being presented with these massive bills. She eventually died, and she had no family, so we had to crowdfund to organise her funeral and to give her the kind of dignity that she didn't have in life. But in the process of speaking to the other users and coming together, which they did brilliantly, they were both showing respect and support at the funeral, but also challenging their very condition itself. So I think that the political mobilization is vital, and it is about actually standing up and saying this is not part of our ethical vision. This is not, if you're doctors, the code makes clear that you have to provide treatment without discrimination. And I think I think it's professionals standing up as well and joining the other professionals who are organising against the kind of draconian, inhumane, cruel laws that the government keeps bringing in around immigration and migration. So I think it's both being active at the kind of individual level, but also trying to empower people to be agents of change, but also politically seeing ourselves as political animals as well, and challenging the inhumanity of certainly the present government's laws. It's really acting on multiple levels, and both in terms of the confines of your own work, but more widely as well with others. So I think that I think the migrant issue is probably the 21st century issue, and to me there are also connections to be made with climate justice. Migrant justice is also climate justice. It's also social justice. It's also women's justice. It's also sort of global justice. So I think I'm echoing all that you've said, but I think that we do have to rethink in that way.
But the problem with migration particularly, I think, is so deeply unpopular. The narrative has been so occupied by Daily Mail type of narrative that it's really hard to wrench it out of that, because the migrants are here to take our jobs, our money. It's like it's so hard to. One of the reasons I wrote that book was to try and counter that narrative and to provide the economic arguments as to the benefits, because some people felt that why do you even have to go there? Why don't you do it? Why don't you argue on the basis of principle? That people have the right to travel around the world, and people have traveled around the world forever, and nobody has a right to any piece of land and say that this is mine and you can't come here. But then the arguments around benefits, benefit to yourselves, to your society, to your country, if you can construct the argument around migration on that basis, you have people listening to you a little bit more. But otherwise, we've lost that whole the anti-migrant narrative is so strong in this country. And I totally agree with, if there are sort of upstanding members of our society, people who are involved in medicine, law, or if there was a real kind of growing movement of people saying that this is just wrong, it's wrong on so many levels, to kind of take that narrative back. That's the first step, I think, at least where migration is concerned.
I think that's right. I think the narrative can be overwhelming. I think the politics of migration can be overwhelming. And it can make us feel helpless. But I think we've got to just carve out little pockets and do what we can where we are. And I mean, it's not just connecting at a political level. I think at a human level, people do connect. There is compassion. And I was heartened by the ways in which there was that mobilization against those 2 men refugees in Glasgow.
Yeah.
And the way in which the whole community just came out and said, these are people of our community, we will not let you pass. And that's really heartwarming. And I think up and down this country, there are communities where people have come to know refugees or migrants at a personal level and connect with them and can support schools, ordinary school children, saying to migrant, we want this migrant child in our school, please don't deport her. Or, families where the church and others come together and say, please don't deport. It's not enough to change that narrative, that real, but I think it's something to hold on to, because I think sometimes it can seem too overwhelming otherwise. And it's what you do in your localities and how you can try and encourage that kind of human connection, that compassion, that kind of decency and kindness, bring that back into the way in which we relate with each other. I think that is, that is more doable.
Do you think that conversation is being made harder by this slight attitude to scientists, medics, doctors being considered to be living in an ivory tower, and the whole expert not part of us conversation? Because I must admit, when I sit and I have these conversations, and I'll have them with, in previous times down the pub when we could do that, there is this kind of comeback that it's like, well, you're in a position of privilege, and therefore you can afford to tell me that I should be doing X, Y, and Z. And I sometimes feel like that's potentially be really interesting to see what you think. But when we have conversations against that Daily Mail narrative, sometimes I feel like that's what you come up against, which is why it's really empowering to hear that small change actually may be the first step. But I don't know whether you think that that's got worse, or alongside that kind of,
But
we don't listen to experts.
I think something really strange has happened during COVID times, because the right have been fighting for the right to travel freely and to have no borders, and the left have been saying, no, we can't afford to spread COVID. So there's been a little blip, I think it's a blip, and it's very related to COVID. But
I think it's also dangerously like national socialism rather than socialism, and that's what the rhetoric seems to be around that.
But the uproar about the sort of like the list in which the countries have been placed, and I've been thinking, when did holidays become a human right? And how angry we feel that we haven't been able to go on holiday for 18 months. Okay, that's I can see how there are benefits, and being in the sun is great, and you get vitamin D and all that, but it's kind of, it's not truly a human right. I haven't seen my family for 2 years. I'm Spanish. I still haven't been to Spain. I've been vaccinated for months, but I haven't been. My mum and dad are 78 and 80, so 2 years without them at that age. It's not the same at my age, but I haven't been, because I felt it's not just for my benefit, but the person driving me in the tube to the airport may have not had the vaccine. The people selling in the shops may have not had the vaccine. So again, that privilege of the medical professional, the nurse has had the vaccine, so then can go on holiday, see the family, because it's all right. And it makes me feel really uncomfortable that we have, the narrative of let's see what country goes into the green list. And again, traveling is not just for holidays. There are very important reasons why people may want to travel. But this holidaying as a right feels really wrong when then we say to other people, no, you cannot travel here for whatever reason because you didn't do what we said, you didn't get in the right queue. Well, try to get in the queue.
Didn't have the right visa, didn't apply in the right form. I mean, that's what we were told, in this context, you have to apply to the right form, so you can't come, you can't come to this country because you've got a visa through some process that may or may not properly apply to you. I mean, coming back to Pragma's point, I think the only way, obviously we have to do broader policy campaigning work, that sort of work that we do, say for example in Liberty, but on a personal level, I think the personal is the political. Everyone you tell stories, that's how human beings, that's what Rahila been so brilliant at, was to tell people stories. People don't want to listen to cases, they don't want to go they don't watch the law, legal cases in the High Court. They want to hear stories about people and the way their lives are affected by migration, and that informs the sort of your collective psyche about why you have empathy towards people that you don't know, even if you don't know them personally. And that's it's education and storytelling, which can I'm used to teach children about the Human Rights Act in school and through citizenship. That was one of the things the Labour government did, which I don't think really happens anymore. But teaching people about migration should be part of school education, because otherwise you're kind of confronted with stories you read in the newspaper and no actual basic knowledge about those sociological until you get to university perhaps, but you wouldn't learn about it. It is actually part of what education should be, and I do think now that children at school identify that the education system is massive overhaul. What children are taught is the same thing that I was taught when I was at school, and that was quite a long time ago.
Good. Well, congratulations, and what's your next opera going to be?
Well, we went to Tosca last summer.
Thank you so much, everybody, and thank you everybody for coming along today.